Today, we're going to discuss a very important topic, and that is complications of acute ST-elevated inferior MI. So, let's see a case. Mr. Smith, 45-year-old man, presents to the emergency department with a sudden onset of central chest pain, which started 45 minutes ago while he was watching television. He describes it as a severe, pressure-like and radiating to the left shoulder and jaw. He is diabetic and hypertensive. Then you perform an ECG, and here is the ECG. So what you get from that ECG? You see there is ST elevation in lead 2, lead 3 and AVF. So your primary diagnosis is acute ST-elevated myocardial infarction in inferior surface. Okay, so today we'll discuss about the complications of acute ST-elevated MI inferior. But before discussing the complications, let's see what happened in acute ST-elevated MI inferior. So in acute ST-elevated MI inferior, this inferior surface is infarcted. So what is the culprit artery or involved artery here? So let's see the artery supply of heart. We can see here there is arch of aorta. Here is arch of aorta, and from the root of the ascending aorta, here there is right coronary artery. Here there is right coronary artery, and here there is left coronary artery. So after arising from the root of the aorta, right coronary artery travels this way, and then it just goes back to the posterior surface like in this way, and it travels through the posterior interventricular groove and becomes the posterior interventricular branch, and then it goes towards the inferior surface, and at the apex of the heart it meets with the left circumflex artery to produce the crux of the heart. Okay, so we can see here the infarcted area is in the inferior surface, and supplying artery is right coronary artery, right? Okay, so now we will discuss about the complications of inferior MI. So now we understand that inferior MI happens due to blockage of the right coronary artery. So what are the other structures which supplied by right coronary artery? So here we can see it is right coronary artery. So after arising from the root of the aorta, it supplies the uh, SA node. Here is the SA node. So it supplies the SA node in more than 65% cases, and then it supplies the right ventricle. Here is the marginal branch. This marginal branches supplies the right ventricle, and then it goes back, and there is a recurrent branch which supplies the AV node more than 90% cases, and then it goes to the posterior surface and produces posterior interventricular branch which supplies the posterior surface, and then ultimately the inferior surface. So what happened if this right coronary artery is blocked or occluded? So the this structure which get supply from the right coronary artery, they will also affected in inferior MI. Now see the consequences. There is acute ST-elevated myocardial infarction inferior. So affected artery is right coronary artery. So what are the other structures get supply from the right coronary artery? From them, first one is SA node, which gets arterial supply from the right coronary artery in more than 65% cases. So if SA node is affected, the heart rate will be reduced. That's why bradycardia happens. So as a complication of acute ST-elevated MI inferior, we will get bradycardia. And then right coronary artery also supplies AV node in more than 90% of the cases. So if AV node is involved, then what happened? There will be AV block. It might be AV block. So it may be first degree or second degree or third degree heart block. Then right coronary artery also supplies right ventricle. So if right coronary artery is affected or blocked, the right ventricle will also may get infarcted. So what happened? There may be right ventricular infarction. So if the right ventricular infarction happens, the patient will have profound hypotension. And how we suspect that that patient has right ventricular infarct? We will see the ECG very carefully. Now on the ECG, look carefully. If you find there is ST elevation in lead V1 along with ST elevation of inferior leads, you will suspect this patient might have right ventricular infarction also. Then you have to take a right sided ECG. You need to just reverse the chest lead from left side to right side in this way. And if you find there is ST elevation in this right sided ECG in lead V4R, like this, there is ST elevation in lead V4R. So then we will confirm that this patient has right ventricular infarction. And these types of patient usually presents to you with profound hypotension, and you will find the lung clear, but there is raised JVP and hepatomegaly. So what you need to do, you need to give preload to that patient, and you have to give fluid challenge. We know that right coronary artery also supplies the posterior surface. We can see here this posterior interventricular branch of right coronary artery supplies this posterior surface. So if the blockage of right coronary artery happens here, that is proximal to the interventricular branch, so posterior surface will also affect it. So we called it as acute ST-elevated MI with posterior extension. Now if we look at this ECG very carefully, we see there is ST depression with positive R and T wave in the lead V1, V2 and V3. So if we see this picture in this ECG, we will suspect this patient might have posterior extension. Then what we need to do? We just turn the ECG upside down and look at the ECG paper from behind at the lead V1, V2 and V3. What happens? Then this ST depression converts into ST elevation, and this positive R wave converts into pathological Q wave, and this positive T wave converts into T inversion. So then what we need to do? We need to do a posterior ECG, that ECG with posterior lead. There are three posterior leads, and that is V7, V8 and V9 leads. And if we look at the ECG after taking the posterior lead, here there is typical ST elevation. Here is the typical ST elevation in V7 and V8 lead, which has taken from the posterior surface. And after looking this ECG, we can confirm that this patient has acute ST-elevated MI inferior with posterior extension. So as a summary, what we can say, from acute ST-elevated ST-elevated MI inferior. As a complication, there may be bradycardia due to involvement of SA node. There may be AV block like first degree or second degree or third degree heart block due to involvement of the AV node. And there may be right ventricular infarction due to involvement of the branches supplied to the right ventricle, and patient may present to you with severe hypotension. And lastly, you may also get posterior extension of the ST-elevated MI, and you will find it by doing posterior ECG with posterior leads like V7, V8 and V9. Thank you very much.